and this is bilateral, right and the left. Now this patient was operated in Mumbai, and see the sequence of events that took place. This is the lateral for the right and lateral for the left side. Immediate post-operative, the stitches are still on. I would like to know if somebody likes to make a comment about this post-operative right, and I will also show the left. There is an attempt at lateralization in both the knees, but this is what is this immediate post-operative status. Now let's see how things have progressed subsequently. These are the lateral views. Patient came to me at this stage and went back to the original surgeon, and he said he will like to revise. Patient, as was being taught this day, that no Indian patient ever prefers revision. So she came back to Patna and said, I would not like it to be revised, do something. At this stage, I started treating the patient for osteoporosis. And so, since the patient has refused revision, to salvage this situation, thought of combating osteoporosis, now which agent is to be used? Anti-resorptive or anabolic? Now, this is an old saying that since we have been moving on, anabolic is a better choice, and in this particular patient, we chose teriparatide. Now, this anabolic teriparatide has the credibility of restoring microarchitecture, increases remodeling, there is greatest reduction in the risk of fracture, and once daily administration, as many of us are practicing, it restores the trabecular and cortical bone surfaces by preferential stimulation. Those all of us are familiar, administered initially under circumstances in which patient can sit or lie down if symptoms of orthostatic hypotension occur. Use of the drug for more than 2 years during a patient's lifetime is not recommended. In this particular patient, it was used for 1.5 years. Now, the biochemical turnover markers, they become important when we treat the patients for osteoporosis, and they most commonly which are used are PINP, PICP for bone formation, and for bone resorption, CTX1 and NTX1. Now, following treatment, this patient, and you can see that there was subsidence of the tibial tray, and at the end of 1.5 years, the patient was comfortable and could walk much better. But the subsidence kept on growing. This is the clinical photograph after 1.5 years. The video you have seen already, the patient was comfortable. So with this phenomenon of subsidence in total knee replacement, there is the moot question that is pre-operative evaluation of osteoporosis important? All of us know what is normal T-score -1, osteopenia -1 to -2.5, and real osteoporosis -2.5. We are all familiar that with a proper architecture you can put more load. So architecture of the bone becomes very important. Aim of this presentation is that we should ponder before TKR, identify patients of osteoarthritis with low preoperative bone mass. The diagnosis in each patient of osteoarthritis, I very strongly feel that this also should be one of the parameters before undertaking knee joint replacement, in which vertebral imaging and biochemical markers, they become important. Well, all of us are aware by treating patients of osteoporosis, even in other patients, that there is a FRAX tool developed by WHO to evaluate fracture risk of patients. And the FRAX algorithm, they give 10-year probability of a fracture. All these risk factors are included in this risk assessment, and this is the questionnaire, and this is how we know the percentage of probability of getting a fracture. Let's not go into the details of the various pathways for osteoblastic and osteoplastic activities, but for a moment, let's know about the pharmacotherapy of osteoporosis. One drug I have already talked about is teriparatide. The other drug which has already been approved by FDA is abaloparatide, strontium, denosumab. They are also in use, but the two newer drugs, romosozumab and odanacatin, they are also important. But talking about osteoporosis, we must emphasize that adequate intake of calcium and vitamin D is equally important. All of us are aware about biphosphonates, but the drug holiday that we have to take after 3 to 4 years is very much important. Now, these are the other drugs, abaloparatide and strontium, denosumab, romosozumab, and odanacatin. So these are some of the drugs which can be used. Now, stem cells of late have become the trend, and age-related decline in osteoblastic progenitors in bone marrow, MSC, can be used. To achieve therapeutically significant bone regenerative effects, MSCs are isolated from marrow, cultured, expanded in vitro. They are infused back to osteopenic patients to replenish stem cell pool. Results in positive bone balance, regeneration of osteopenic skeleton takes place. It is also necessary to either combine MSCs with an osteoinductive carrier or provide autologous stimulus BMP into the cells. So, friends, finally, caution is proposed, and hold your hands or perform TKR, but definitely see that osteoporosis is tackled. If the preoperative BMD stands at T-score of -2 or less at lumbar spine, total limb and femoral neck, or the T-score is -3.5 or more at each one of the 3 sites. So to conclude, effective strategies to prevent bone loss and to treat osteoporosis include calcium and vitamin D and biphosphonates administration. The newer drugs have definite advantage.
Yeah, thank you very much for a very interesting topic. I think that's when you're operating and you find that there is porosity and you're cutting through cheese instead of bone, then it behoves you to put a stem into the tibia at least. So that gives you greater stability. The second thing is that just like when you talk about fractures, you have mechanics and you have biology. Here clearly, whoever did this in Bombay did not look at whether the end result was varus or valgus or neutral. I mean, when all of us are standing, we are supposed to be not standing with our hips, with our femur going in like this and our tibia like this. But that is the way most of the literature has recommended, that in the end you must get that degree of valgus. And if you look at what has come from America, from Insal's team, it's not 5 degrees, it's 4 degrees that they have recommended. If you have a very fat patient, maybe you need to have 3 degrees. So those few nuances have to be taken into account when you're doing a knee replacement. And I'm very pleased that Dr. Jha could show that in case of osteoporosis, the patient could be made stronger with these newer drugs. Teriparatide takes a little bit of time to act. Denosumab, as he mentioned, is the newer drug available. Costs 18,000 rupees for a single injection to be taken once in 6 months. Whereas teriparatide is single injection taken every day for a period of 1.5 years. So maybe your patients might opt for something else other than the bisphosphonates, which you've heard me talk about for AVM for years. And quite rightly, as he pointed out, there has to be a drug holiday if you're taking bisphosphonates, because beyond that, then you start getting problems. Bisphosphonates cause sclerosis. So I think that is a very interesting thing. If you get osteoporosis in a patient, you need to correct your biology, which is all this, and correct the mechanics.
I think this was osteoarthritis knee, and it developed osteoporosis, and it is totally a mechanical failure. I think it looks a mechanical failure, and on X-ray you cannot say what was the ligament balancing, what was the exactly implant. Only APM, let's say, you cannot know the biomechanics of the total implants and all these things. So it was totally mechanical failure. I think it's not the osteoporotic failure.
Dr. Can I add one thing? It is a rule of thumb, if the patient is obese, she was obese and osteoporotic, it is, as Dr. Agarwal said, always use a stem. It is always on the safer side.
I don't think this is a primary osteoarthritis, and without stem it can do very well, because there is a definite indication of a stem. If it is severely osteoporotic, you can go ahead with the stem, but in the routinely we don't need it, because there is no bone loss exactly to get with the stem. Stem has proper indications.
Disadvantage, imitation as well, and that kept on increasing. So the next case, here is the...
Dr. Bansal wants to say something.
As I said in the first session, that all of the patients were doing total knee replacement. They should have a proper assessment pre-operatively. One is that, all the X-rays, everything is there, but we must make a protocol to do some investigation of the patient where we are doing total knee replacement. For example, the investigation, namely calcium, phosphorus, and phosphatase, and then vitamin D, vitamin B12. And finally, of course, I would recommend that when you see, most of us can expect CV from the X-ray that patient is osteoporotic or not, but we can't confirm it. So it's better to the BMD as well. All these investigations should be make it a protocol to do it before doing surgery. Thank you.
Stage of osteoarthritis of the knee. When the patient comes to you and you evaluate the patient for osteoporosis and treat osteoporosis, surgery can be deferred for quite some time. Well, coming to the case 2, this is really a complex osteoarthritis of the knee. This patient was operated in Delhi. The patient is otherwise very comfortable. He has got active extension of both the limbs. He has full flexion of the knee in both the knees. His disability becomes apparent when he tries to put his knee in figure of 4 position. And you hear and feel Now this is the posterior aspect of the knee where you can palpate a bony prominence on the right side. Can I play it? Yes. Now you can see there. This is what is happening in this particular joint. This is the right joint. And look at the X-ray. There is dislocation, and like invariably majority of the dislocations, it is a posterior dislocation. But here also the patient refuses to be operated again, and he says that he is otherwise very stable if it does not relocate. The patient is, when it is not relocated and auto-reduced, the patient is walking comfortably. No, it has happened non-traumatic.
I think
This is the APL lateral views. No. That's
Okay,
it.
I think we will start questioning a couple of things. Number one, there is a dislocation we all have seen, there's nothing great. And we have seen the pre-op X-ray and the post-op X-ray. So can I ask Dr. Sanjay Agarwal first, could it have been prevented? That's the first thing. And if, how? What step somebody should have taken during surgery so that it will not happen?
Again, it boils down to biology and mechanics. Clearly, there was a great deformity here, and I would suspect a large amount of clearance was done. The alignment, right? In the process of getting the alignment, all the ligaments must have been cut and released. And it behoves not only to use the rod which was used in this, like I said in the last case. The rod was used, it stabilizes the tibia on the tibia. But you need to do something to get greater stability between the femur and the tibia. It doesn't necessarily mean that you need to have constraint implant, which itself has its own problems. But this kind of a knee should have been possibly treated with one of the inserts which are more stable. And there are 2 or 3 in the market which are compatible with the knee that you are doing. One of them is the Smith and Nephew, where you have a thicker post, and the thicker post along with that you get greater stability. There so that gives you more stability. So this should have been anticipated so that greater stability between the femur and the tibia was done. So they looked after the tibia to tibia by putting the rod. But I think this is what was missed. And in case this happens and you are totally unprepared, you and I have seen knees, if you've done enough, you've done 5 knees, you've seen. If you have a knee that you have immobilized for a period of 3 weeks, it gets stiff. This kind of a knee should not have been mobilized immediately after surgery. It should have been put into a suitable splint or a plaster. Allow the tissues to tighten, which they tighten amazingly fast because you've done so much surgery, and then you would have got greater stability. You may have had a decreased range of movement, but greater stability is what is required in this case.
That we don't know, because the point is he started walking and he used to complain of his stability, but he was walking well. This is what Dr. Jha said. He used to walk well and he had instability off and on. So that can be one reason. Any difference of opinion, Dr. Maheshwari and Dr. Reddy? Anything else you would like to say? Something could have been done, or a hinge joint to start with?
Yeah, as rightly said, hinge kind of a setting which would have prevented this scenario.
Dr. Maheshwari, any extra thing?
On right side, the surgeon was not comfortable. You can see from the cut, the distal femoral cut, the way he tried to build up the medial condyle of him. You can't build up like this. And the rod is also hanging in the air actually. I'm quite surprised that the medial unit has not become loose as yet. So I don't think there was a technical understanding problem here. And surgeon did not expect it. As I was telling you, do not prepare for the case. All the results may not have been there. Such a difficult scenario. But I agree with Dr. Reddy. If I'm doubtful, one option the patient has, I would not hesitate to go and put a hinge. If on the table I'm doubtful, I don't believe in God. I believe in myself. It has to be stable. If it is a little bit unstable there, I don't believe in God that I will mobilize it and sort out solve it. It may or may not happen. Later on, everything is going to become more difficult. Now removing everything and doing even a hinge is going to become a terrible job. So I would rather at a trial stage take a decision. I might, if I don't have an implant, I'll close the wound there, tell the patient I'm going to come back tomorrow morning again. But once I fix implants, then to revise it is a Herculean job. Even a hinge may not give you the right result. So that's my approach on day one if I was stuck like that. Now of course there is no other option but to use it.
Okay, so this is a problem of fracture patella in the case of either a UKR or a TKR. We all have cases like this. Nothing